This morning, we're going to change directions to coronary CTA, talk about how to utilize coronary CTA in 2022, and integration into the ER. So without further ado, we'll talk about modern scanner protocols, coronary CTA acquisition, utilizing coronary CTA in the emergency department, and then we'll change gears and talk about beyond anatomical imaging with CT FFR and CT perfusion, and then we'll round it out with ablation imaging and cardioversion imaging, which can also be performed in the emergency department. So I want to go back and just review a little bit of the literature about coronary CTA. It's quite robust. We've been doing coronary CTA since the 90s on early generations scanners. The early studies were all performed on 64 slice scanners in the early 2000s. We've come a long way since then with our 256, 320 slice scanners with 16 centimeter detectors. Or also dual source scanners like Siemens Force with rapid temporal resolution. And what that affords us is really decreased contrast dosing, less radiation, and then improved accuracy as well. So we've got excellent spatial resolution, and it's a very fast, non-invasive test. So when we look at some of the landmark trials, accuracy, Core 64 were really two of the main ones that got us starting to think that, wow, coronary CTA really is the best way to look at patients with chest pain and evaluate for obstructive coronary disease. These studies compared the sensitivity, specificity, and diagnostic accuracy, and they were all performed on older generation scanners. And they looked at degree of stenosis in a decent number of patients total. And they found there was a high sensitivity and a high negative predictive value. And so we look, here's just an example of the accuracy study, which came out in the early 2000s, just demonstrating high sensitivity with coronary CTA. And Core 64 looked at comparing coronary CTA to invasive angiography, and they found that quite comparable. So there's really extensive literature supporting coronary CTA as the first-line therapy, but the question is, can we do it out in the emergency department? Is it cost-effective? How is it related to ER throughput? When you look at cost in the emergency department and ER throughput, is it cost-effective? And then is it worthwhile? Is there a survival benefit related to earlier diagnosis of obstructive disease and utility of medical therapy? And we'll talk about that a little bit, especially with ischemia trial coming out and some of the additional trials that have been published in the last couple years, really demonstrating that medical management is just as good as some of our invasive therapies. And then also comparing the radiation dose to nuclear stress testing. A lot of times we don't think about the radiation that's associated with myocardial perfusion imaging. But when you look at that, this is an older study on 400 patients comparing coronary CTA to MPI. And it's interesting, if you do stress and rest MPI, average radiation dose is 27 millisieverts. And I think a lot of times we don't actually consider how high of a radiation dose that MPI studies are. Today, with some of the newer nuclear medicine scanners, they tend to average closer to 10 to 15 millisieverts, but still that's a huge radiation dose compared to our coronary CTAs, which we're talking about 1, 2, 3 millisieverts. So big difference. Protection 6 came out in 2017. We were part of that study. They had done Protection 5 in 2007, and Protection 5 was looking at radiation doses in coronary CTA in older scanners. And then in Protection 6, it was over 4,000 patients in 32 countries, and we submitted a few hundred cases to this study as well. And you can see that with modern generation scanners, we're less than 25% of the dose that we were 10 years prior. So I think you can understand that now we're talking about 1, 2, 3 millisieverts. That's really a negligible radiation dose. So in 2020, the ACC decided that they were going to make new chest pain guidelines. They were supposed to actually come out in 2020, but they weren't published until November of 2021. A lot of reasons for that. This is a disciplinary group of physicians that got together and a number of societies to make these guidelines. Coronary CTA is the only Class 1A indication for intermediate chest pain evaluation. But it's interesting we don't have time to go through the entire guidelines, but one of the things I found very interesting about their guidelines is that there's no recommendation for imaging for low-risk patients. And so the thing that is challenging for us in America is you have a patient who's technically low risk who returns multiple times with chest pain, and you keep telling them, well, the new guidelines say we don't have to do anything. I don't think anyone is going to accept that, right? So I think we have to use these in a way that are practical for how we address healthcare in America currently. If you have somebody who keeps coming in for chest pain, you're going to do something, even if they're low risk. And so I think you can extrapolate some of those intermediate risk guidelines to the low risk population if they're patients with recurrent chest pain. And so I think that's what we'll do in clinical practice. And so really coronary CTA would be the class 1 indication for those patients as well. So I want to talk a little bit about the investigations that have gone on that have led us to coronary CTA in the emergency department. Scott Hart was really the article that kind of changed the paradigm. It came out in New England Journal of Medicine in August of 2018, and it was a 5-year evaluation of randomizing patients from standard of care, which was myocardial perfusion study or a stress test or a stress echo versus standard of care in a coronary CTA. And what they found is that the amount of invasive catheterization was the same for both groups, but the CTA group had a lower rate of death from coronary heart disease and non-fatal MI, and no increase in revascularization. And so if you look at, here's their invasive angiography, same for standard of care and CTA. Again, revascularization, same rate of revascularization for the CTA patients and the standard of care. But here's the take-home point. The patients who ended up getting a CTA did far better than those who had standard of care, whether it was from death from heart disease or non-fatal MI or just non-fatal MI alone. And so what is the reasoning for that? We presume that it's probably because these patients who ended up getting a coronary CTA, we diagnosed their non-obstructive disease and they ended up on adequate medical therapy. And a number of studies have come out since looking at the efficacy of good medical therapy for treatment of coronary disease. And we know that besides small subsets of patients, patients with severe left main disease or proximal LAD disease, patients who have other coronary disease, whether it's obstructive or not, pretty much do the same with medical therapy or a stent or a bypass even. And so we know that really the standard of care is adequate medical therapy. And so they repeated this study at MGH looking at evaluating coronary CTA in the emergency department. And this was kind of their comparison to the Ramakat study and randomizing patients to CTA versus standard of care and looking at their length of stay in the ER. Over 1,000 patients, 10.5 hours versus 27-hour length of stay in the emergency department. That's quite a difference, and no missed major adverse coronary events. And so when you look at their study, they this is also compared to Ramakat 2, which looked at similar findings. In Ramakat 2, the CTA group was about 8.5 hours. In the MGH group, they actually included patients that got scanned the next day. So if a patient came in, for instance, at 8 p.m., they waited and did their coronary CTA in the next morning if they were in the CTA group. And so they ended up teasing that out. And so patients who had the same day scan, their ER length of stay was about 6.5 hours versus the next day scan was 22 hours. And so if you're an administrator in an emergency department, this is quite a difference if you can get these patients out of the emergency department in less than a third of the time. And so I think this is a great take-home point from this. The patients who had no or mild stenosis, basically 3 years, you have zero risk of having a major adverse coronary event. So you also don't have that risk of doing a stress test for a chest pain patient. The stress test was normal. Well, you still don't know if they have coronary disease or not, right? They passed their stress test, but we've all seen those cases of patients with myocardial perfusion imaging who come back and they have terrible 3-vessel disease, but it was normal, right? So with this, this, you actually know they have no coronary disease. So there's something else that's causing their chest pain. So you can, and a lot of times that's enough to keep people out of the emergency department and coming back with chest pain. Even the patients with moderate stenosis, you can see their 3-year risk of having a major adverse coronary event is relatively low. So let's talk a little bit about new generation CT scanners. We mentioned them a little bit yesterday. There's 2 flavors. We have the wide detector, which allows for single beat whole heart coverage. You can still have cardiac motion on that. If you think about, depending on what your heart rate is, although they can scan it in the single beat time, if you don't have enough diastole where your heart is completely still, you theoretically can have some cardiac motion due to the temporal resolution. And so these modern scanners have developed a motion correction algorithm, and that allows for an effective temporal resolution that's much faster. And I'll show a couple examples of that versus the dual source, which is the Siemens version. Having 2 sources and a much faster temporal resolution, which is great, although the detector is only 5.6 centimeters, so you still have that risk of the misregistration issue. But at very low heart rates, you can actually turbo scan them at a rapid helical mode, and that's a really ultra low dose scan.